Hello, everybody. Welcome to the show today. This is the show for the precious blood of mine, and we really thank you for joining us. And so, with me, I have wonderful group of guests and also great colleagues. Yeah, so I would like to introduce Dr. Jameela Sattar and Prof Yazid over here in the studio. Yeah, and also our colleagues from online, which is Dr. Sunita and Dr. Shahnaz and Dr. Premitha and Dr. Mandy. And later on, we will see our mystery guest, right? Yeah, so today, actually, we wanted to kind of help all of us to kind of realign things, right? So a lot of practices and beliefs that we know actually may not be really the truth. And so we would like to kind of bring out the truth and also to realign matters, and so that we can kind of look forward to better health and better outcome. So maybe just for a brief intro, I would like to actually invite Dr. Jameela. Maybe you can tell us briefly how did my PBM come about?
First of all, it all started in 2010 when I noticed that there were a lot of requests for blood transfusion, which were actually all unnecessary. Most of them were not necessary. So we went about to educate the clinicians on the dangers of blood transfusion and when is the appropriate time, if needed, to transfuse these patients. And I would say that most of the time it's for life-threatening hemorrhage that you need to transfuse blood. And so it came about in 2012. We developed the education module to teach all clinicians from all hospitals throughout Malaysia. And we did this almost every 2 months for the last 4 years, and subsequently we managed to work together with clinicians from various disciplines. And in 2019, with a group of passionate clinicians, we formed the Malaysian Society of Patient Blood Management. And we have done many education workshops, and this is one of them, to educate not just the clinicians, but also the public on the precious blood of mine, how precious your blood is, and how you should actually, you have to treat your body, you have to maintain good health, not just, overall health, but also blood health.
Yeah, that's good. Yeah, so basically, like we have come quite a long way, right? Yeah, so and the reason why we are here today is because of every one of you. It's so that together, like public, clinicians, everybody, then we can actually do something together. And also, maybe just a quick recap of the video one, which we did. It was on patient blood management and introduction itself. And so patient blood management is basically trying to tell us to recognize where is the valuable resource. So the valuable resource, which is the goal, right? It's not the blood that is in the bag outside, but it is the blood that is in our own body. And so we're trying to tell everybody to remember that your own blood is actually very precious. And so we'll do all measures together with everybody to actually preserve it, to conserve it, to optimize it, so that you get better outcomes. And all of this, we are actually considering your own wishes. So basically, you are the goal and something very precious. All right? Yes, so that's a quick recap for video one. And now we get on to our next other video recaps, and we will invite Dr. Sunita, and she will do a recap of video 2 and 3.
Thanks very much, Dr. Ananthi, and hello, everyone. Actually, the second video was talking about the dangers of blood transfusion. So I just want to share with you about all the possible complications of blood transfusions and why we shouldn't be taking this lightly. Actually, I can't see my slides very well, but I think the first, of course, and the most important thing that we worry about with blood transfusions is giving the wrong blood to the wrong patient. That's what we call ABO incompatibility or mismatch. And if that happens, then the consequences can vary from milder reactions such as acute hemolysis, where the red blood cells break down, acute kidney injury, and acute respiratory distress syndrome, and sometimes possibly result also in serious consequences such as death. The second thing that we worry about when we give people blood transfusions is that they may develop allergic reactions. And again, this can vary from milder forms of reactions where patients have fever, rash, or itchiness, but they can also be severe and what we call anaphylaxis. So patients develop a rapid drop in blood pressure and require resuscitation, including IV adrenaline. The other things that we worry about with blood transfusions is the possibility of spreading or transmitting infections like hepatitis B, hepatitis C, newer HIV strains, as well as COVID-19. And there's also the risk for some of us when we're talking about patients with kidney disease, in the sense that they can become sensitized to having foreign or exposure to foreign proteins, and in future they need transplants, then there's a higher likelihood of having rejections. I think I've got another slide as well. So if I could have the next slide, please. Okay, so apart from what I've just mentioned, the other dangers of blood transfusion include transfusion-related acute lung injury or TRALI. And here there are antibodies which form and attack the small blood vessels in the lungs. There's also something called TACO, which is a transfusion-associated cardiac overload. So every pint of blood that we transfuse in patients gives about 300 to 500 mils of fluid. And so that can actually put a load on the heart and cause acute heart failure because of that volume load. And then there's alloimmunization. So that can result in hemolytic disease of the newborn in a pregnant woman, as well as difficulty in getting compatible blood in future. And then last but not least, blood transfusions can also result in immune modulation, and they actually weaken the body's immune defense system. The next video, or video 3, was actually talking about perioperative patient blood management. And actually what we mean by this, if I can have the next slide, please, is that in the perioperative period, that means from the period before, during, and after an operation, we want to make sure that patients will have a good level of red blood cells, and that's what we call a hemoglobin level, throughout the course of the operation, because we can expect that there will be blood loss during surgery, and we want to make sure that it's not going to result in complications for the heart or the lungs during or after the surgery. Could have the next slide. So as I mentioned before, we need to have a care at 3 levels in the patient's journey throughout the operation, starting from before or preoperatively. And ideally, all patients should have a hemoglobin level of at least 13 grams per deciliter or above. So if the patients are not at this target hemoglobin level, then we would normally use iron supplements, either orally or intravenously, to get to target hemoglobin. Intraoperatively, there are a number of measures that the surgeon and the anesthetist can take to try to prevent bleeding or to stop bleeding as soon as possible. So the surgeon will take extra care with the surgery and will stop any bleeding points. The anesthetist will help to keep the body temperature and blood pressures in the normal range, because that helps to reduce blood loss. And sometimes the operation may actually involve the use of cell salvage procedures, where the blood that is lost is collected and then given back to the patient. And at the end of the operation, sometimes the surgeon may give the patients IV tranexamic acid to help to prevent any further blood loss. In the period after the operation, it is important to avoid unnecessary blood tests. We are often given medication to prevent stress, stomach ulcers, because that can happen in the period of the stress of the operation, etc. If hemoglobin level is slightly low, we could get away with just giving patients oral iron and folic acid supplements. But if the hemoglobin is very low, then we want to correct that faster. And this is where IV iron and erythropoietin would come into play. I think that's the end of my slides. And back to you, Dr. Ananthi.
Thank you very much, Dr. Sunita. And that was a very comprehensive recap. And so again, we say like transfusion, do not take it lightly. You have to take it seriously, and also, prepare well for surgery, right? Okay, so next we would invite Prof Yazid. And so Prof Yazid will present on the recap for anemia and iron deficiency, as well as the other one on PITS and ONG, right?
Yeah.
Thank you.
Thank you, Dr. Nanti. Assalamualaikum warahmatullahi wabarakatuh, and good evening, everyone. Thank you for joining us this evening. So what I'm going to recap to you is on the video 4 and video 5. So for video 4, it's basically about a lady who had chronic blood loss because of fibroid and hence need to go for a surgery. And prior to surgery, the hemoglobin level was 6 gram per deciliter. And because of that, there was a need to transfuse, and she was not very keen on transfusion. And as a result, consulted the patient blood management team, and she was given iron infusion. And for video 5, there were 2 scenarios. First scenario is basically of a 6-month-old baby who was an ex-premature, who were growing very well without any symptoms, just having some pallor with hemoglobin of 5.5. There was no overt symptoms, no heart failure, and all those acute illness. And this baby was again planned for transfusion, and because of going through all this patient blood management, we then decided to just give the baby oral iron therapy and avoided the need for the iron transfusion. And for the third case is basically the mother who's pregnant and having anemia, and again the treatment for that mother is basically by giving iron injections. And all the 3 cases basically tells us that when it comes to anemia, especially due to some chronic illness or chronic blood loss, you do not need to transfuse them, and you do not need to just depend on the number of the hemoglobin value to make that decision to transfuse them. And now I'm just going to give you an idea what anemia is actually. When we talk about anemia in children, the number actually differ depending on the age group. And if the child is below 6 years old, anemia is defined as hemoglobin of lesser than 110. But when the child is between 5 to 11 years, it's 115, and between 12 to 14, it should be less than 120. For non-pregnant women, 15 years of age and above, again the number is 120. But for pregnant women, anything less than 110 is considered as anemia. For men, basically anybody who is above 15 years old, anemia is defined if the hemoglobin is less than 130. So as you can see from there, the numbers differ by the age of the patient. And in the video 5, we also talk about the prevalence of anemia in children. And in Malaysia, almost 1 in 4 Malaysian children under the age of 5 are anemic. And this is something that is very important for us to understand, because anemia, chronic anemia can also cause issues to the brain development. And because of that, there's a need for us to screen these children for anemia and prevent them from going to having problem with anemia. Basically, if we look at the causes of anemia, basically because of iron deficiency anemia, this is mainly as a result of the diets that is low in iron. And again, for children below 5 years old, this is in relation to the poor complementary diet. Body changes as well in children because of their rapid growth. They need more iron, and if we do not supply enough iron to them, then they may have anemia. Other abnormalities that lead to iron deficiency anemia, such as blood loss from the gastrointestinal tract abnormality because of the blood loss due to the menstrual bleeding or even injury. And as I mentioned earlier in video 5, it is because of the fetal growth and placental needs. Just going through the people who are at risk of anemia, basically for children and adolescents, these are those children who are born premature, those who are not fed with iron-rich foods, those with health issues such as chronic illness or on strict dietary regime, and children between 1 to 5 who are exposed to plumbum or worm infestations. And not to forget the adolescent girls who have heavy menstrual bleeding. As we mentioned earlier, also pregnant women, as well as those with chronic illness and those who take inadequate iron-rich foods like the vegans and strict vegetarians. Symptoms of anemia, as mentioned in video 4 and video 5, mainly related to lethargy, pallor, as well as shortness of breath or palpitation. Some children may have a problem with fragile nails. They catch flu easily, or they have painful tongue. A number of adolescents may have headache or dizziness, especially after changing posture, and poor concentration in their studies. What is the impact in the long run? Iron deficiency anemia, if it's very chronic, can cause impact in the growth and development, impact in cognitive and also motor function, and they also may have problems with fatigability and lethargy, as well as impact immune function. So what do we do, especially in children, is that we need to make sure that the pregnant mothers receive their usual antenatal care, including the iron and folic acid supplements. And if this mother continue to breastfeed their children, they should continue on all these supplements to avoid anemia itself. And it's also important for us to have the changes in the eating patterns to increase the iron bioavailability and absorption, and to consume enough food and milks that are fortified with iron, and also have higher accessibility to, and also increased consumption of iron-rich foods. We also need to promote better understanding of the importance of nutrient-dense and varied diet, especially for young children, and promoting the screening for iron deficiency in early childhood. This is just to give you an idea about the sources of iron coming from the heme iron or the animal foods, or the non-heme iron from the plant foods. And how can we improve the absorption of iron is basically by taking vitamin C together with the foods. That will increase at least of about 4 to 6 times better absorption of iron. And these are all done basically to avoid these problems of anemia. If we need to treat these children, it can be given through oral iron, either through syrup or tablet, using this formula here, 6 milligram per kilogram per day of elemental iron. We seldom need to use iron infusion, but as again in video 4, when you have a chronic chronic anemia for some time, and you want to prepare them to go for an operation, the easiest way to do it is by iron infusion rather than by blood transfusion, as we talk about tonight. So basically, this video 4 and 5 giving you the different scenario of patients who have anemia, that we can avoid blood transfusion if we do it correctly. Thank you. Back to you, Dr. Nanti.
Thank you very much, Prof Yazid. So that was a very comprehensive video recap. And so, yeah, since we are on that topic, then I might just come back to you. Yeah. So, like you were telling about the symptoms of anemia and, iron deficiency, it seems very vague, right? Yeah, something that, sometimes we might say, I'm feeling very tired, or I just cannot concentrate at work. So we might say, oh, maybe you didn't rest enough, or, So as for kids, like how do you think, that affects the difficulty in the sense of people detecting it?
Yeah, thank you for that. Yes, I totally agree. A lot of all those symptoms that I mentioned are basically very general, unless you do a proper screening, right? Even as we talk about the video number 4, the hemoglobin level was already 5.5, and the only thing that you've seen was just pallor. So again, to me, moving forward, looking at all these problems of anemia, I think screening is very important. And if we want to do screening, we should go for the non-invasive screening rather than invasive screening. And I think at present, I think there are some studies in the US. They have also done some studies in Africa and in Bangladesh, whereby they use something similar like your oxygen saturation, that you can actually measure hemoglobin level. So they call it that, the saturation concentration of hemoglobin. Yes, it's not very accurate, but I think it's still a good way to screen. And I believe for children below 5 years, that would be a better way of looking at their anemia. by doing a better screening, because we do have children coming to clinic kesihatan, the maternal child health clinic, for screening of their growth and their development. Why not just add in another screening for anemia? Yeah.
Yes, that's very good actually, because I think many people would be afraid to actually poke a child, right?
Exactly.
It's not
Yeah.
something easy.
Yeah.
And like you say, also children, because the blood volume is less, and indeed the blood is even more precious. So
Correct.
yes, using a non-invasive method is something very good. Yeah, and Dr. Jameela, I always remember that you always say, you know, like the patients should ask, isn't it? What is my HB level? Is
Yeah.
that right?
Yes.
Yeah. Mm.
I think that is very important. Yeah.
Mm-hmm.
To ask for your hemoglobin level, especially when you see the doctor.
Yeah.
Because you can actually, if you're anemic, you can actually correct the hemoglobin with other means. Yeah. And especially for those women who have bleeding, disorders, and they have heavy menstrual bleeding, yeah, definitely you'll be iron deficient. So you need to actually look out for your hemoglobin, yeah, and manage it accordingly by taking oral iron. And if you're very iron deficient, then you may need IV intravenous iron. Maybe I could ask Prof Yazid,
Yes.
a question, because over dinner you mentioned that you had experience in treating a child with Jehovah's Witness. Yep.
Yeah.
Can you?
Yes.
Discuss
That was back, I think, more than 15 years back when I was a young lecturer at that time. So at that point in time, we came across a baby in the NICU, our neonatal intensive care unit, who were born premature. And this baby was born in a family who practiced Jehovah's Witness, meaning that no blood transfusion. I think everybody was very jittery at that time. I mean, how come we take care of this baby when at one point you need to transfuse this baby because the baby was premature. But I think at that point in time, the consultant neonatologist, Professor Siti Lim, was, we had together, we had a good meeting with the parents and among us to decide on how can we do this best. And I think things that came out from there was that we tried our very best, so-called not to do unnecessary blood taking. We only do the blood taking whenever the baby is really having a lot of symptoms that we need to understand what's going on. And on top of that, we actually start the baby on erythropoietin. And that helps to actually prevent us from transfusing the baby. So the baby, successfully leave the hospital without any transfusion, and the baby is alive. So that was 15 years back, and it's still very fresh in my mind because that's the first time that we have to, try to make sure that we are not transfusing a baby with premature, and usually premature baby, one way or other, you likely need to transfuse them along the way before they get discharged from the hospital.
So I don't see why you can't translate it to all those babies out there who are not, from Jehovah's Witnesses parents, yeah, right?
Yeah.
So it's doable, right?
It's doable, and I would say it can be done, but it needs to have a commitment from everyone. And you need to make sure that everyone understand the needs of minimal blood taking in this group of children, unless the baby do have complications like pulmonary hemorrhage or even intracranial hemorrhage because of their prematurity. That's a different story. For those group of babies, when the hemoglobin drop very fast and they have symptoms, yes, you may need transfusion. And I guess in that situation, as I said, acute illness causing you to have symptoms, even like heart failure and all that. I mean, by all means, if you need to transfuse, you transfuse. But if you can avoid transfusion by other means, I think you should go for that rather than transfusing baby. Yeah.
Yes. So that was a really good experience.
Yeah.
And in a way that, like what Dr. Jameela said, the principles can be something that can be applied to everybody. And yeah, we were just discussing, and perhaps the maybe audience would later watch the video and
Yeah.
see too that there is the experience that is shared by the Englewood Hospital. And so they mentioned like 20 years of these strategies that they use, like PBM or bloodless medicine. And yeah, on even premature baby, of using iron and erythropoietin, like what you mentioned. So yeah, it's like you said, also perhaps time to move forward, right? Yes, right. So also maybe we have some questions, maybe also for Dr. Shahnaz, perhaps, since we talk a lot about the dangers of transfusion, right? So actually, like from your side, because you're also doing transfusion medicine, and so your side also, you mentioned, can you tell us what do you think about that? Like, why do we really need to avoid it?
Thank you, Dr. Ananti. Hi, everyone. Blood transfusion is actually part of modern medicine treatment, but of course, it's not without risk. Therefore, the decision done by clinicians when they want to transfuse, the benefit must always outweigh the risk. The risk of adverse transfusion reactions is always unpredictable. It differs from one patient to another, and the reaction can be mild or even life-threatening in some instances. So patient might show sign and symptom of having transfusion reaction. I mean, it's very unfortunate because they have been admitted to hospital and they are suffering from the current diseases. But on top of that, because of some transfusion might be not indicated in their cases, what happened is they experience signs and symptoms indicating that they are experiencing some sort of adverse transfusion reaction. It can be mild, such as having rashes, fever with chill or rago, or it can be as bad as having renal complication, or they can have respiratory distress and whatnot. And I like to emphasize that blood is a very precious resource, and this is not easily, we cannot easily get blood. It's not like medicine where you can get over the counter or you can purchase through manufacturing or whatnot, but it comes from eligible donor. Yeah. And because of that, we really have to be very stringent when we decide to use the blood. And therefore, actually, like what Prof Yazid mentioned earlier, there are so many other, most of our anemia is not because of failure of the bone marrow to produce normal cell, but most of it because of nutritional anemia, which can be treated by either modalities such as IV iron or oral iron. And like I said, this transfusion reaction, it can be mild, such as having rashes, but also I would like to emphasize there are severe or potentially life-threatening conditions, such as having acute hemolytic transfusion reaction, where there is an incompatibility between the transfused blood with the patient's antibody, where this can lead to multiple problems, such as intravascular hemolysis. The incompatible blood is lysed intravascularly, or patient might experience formation of thrombus, or even, this will lead to release of chemical in the body, inflammatory chemical, vasodilation chemical, which eventually will lead to multiple organ failures, and of course, it can also lead to death. Therefore, we really have to really think, especially the clinician and even the patient themselves, they have the right to ask whether that is the decision to transfuse, is it really indicated, or is there any other modalities? Because transfusion should be the last resort where all other alternatives have been tempted or failed. Yeah. So therefore, despite the transfusion reaction that I mentioned, life-threatening acute hemolytic transfusion reaction, you have also what you call TRALI, transfusion-related acute lung injury, where actually what happened, patient might need mechanical ventilation support because the failure of the lung due to accumulation of fluid in the lung tissue, or patient with cardiac diseases might also experience TACO, or what we call transfusion-associated cardiac overload. And despite the other thing that we're worried about, despite of stringent donor selection, eligible donor selection, and also all our blood 100% molecular tested, or what we call nucleic acid tested, unfortunately, there is still possibility of patient contracting diseases through transfusion, because the disease itself. If a donor being exposed, so a few days after exposure, the body has not have the time to develop antibody yet, and the viral load is very low to be detected by the current analyzer that we use. This virus can actually be transmitted to the patient, and patient might develop, such as syphilis, hepatitis C, and even HIV. And on top of that, we do not, according to WHO, we do not screen all the microorganisms out there. There are diseases can be transmitted like dengue. We do not screen for dengue, but it can be transmitted to blood. Therefore, that's why we like to emphasize in patient blood management. Transfuse when really indicated. Patient's own blood is very, very precious. Actually, there's a lot of modalities that we can use to optimize the patient without using blood. So we want to use blood for patient with marrow failures, such as, for example, patient with aplastic anemia or patient with thalassemia, where they really need transfusion. So this kind of patient that we need to focus, or patient with acute massive bleeding, to use the blood. So the other group that is not indicated, that one we can focus on other modalities to treat them. Other than, despite the infection and the risk, of course, it will prolong patients' stay in the hospital because of whenever they develop reaction, we have to monitor as well. And actually, it can also cause patients to have iatrogenic anemia on top of that, because we have to take blood, blood to test the patient as well. And on top of that, of course, the cost and the wastage. The cost of screening is very high. With current condition, I think a unit of blood bank can reach almost 1,000 ringgit. So that's why we need to use the blood judiciously.
Thank you very much, Dr. Shahnaz. Yes, so definitely, we can see a myriads of very bad effects if we actually use a transfusion. And so, if you actually think of any drug having all these side effects, would we actually use it? Right? So in that sense, this is something that we really need to look into. And again, a blood transfusion is not a drug, right? Like you said, it's something much more. It's actually something that we need to really consider seriously. Right, so we quickly go through. Thanks very much. We can perhaps ask maybe, some of our other panelists as well. Maybe Dr. Premitha, you also have experience in the OB-GYN, right? Yeah, so in how you actually employ or use patient blood management in your patients. Yeah.
Well, I think I've been using PBM for the last 3 years, and I've actually learned a lot with my patients practicing PBM. What I have realized is that the hemoglobin levels do not reflect how good that woman or a teenage girl or woman is, because many times they come to me and they say they're tired, and of course, anyone can be tired. Many times I'm also tired. When you go on and ask them a little bit about their dietary history, and I always ask a lot of questions about periods, because I find that many times what they think is normal is actually not normal. And, they are bleeding a lot, they overflow, but they say, no, it's only for 2 days, but I use maybe 8 pads a day. But, these are very significant amount of blood. They don't seem to realize that. And then I start talking to them about whether are they on iron tablets? And there's always this big misconception about iron tablets. Number one is that it will hurt your liver, it will hurt your kidney, it will cause constipation. And I keep telling them that's the easiest thing that you can do to actually give back your own blood, to put it back into your body. And then they said, oh, I'll only take it during my periods. And then after that, I won't take it. So all these misconceptions are something that I sit down and I talk to them about. And I talk to them about, the fact that you can find the ideal iron tablet that suits you. And even if you correct, and, many of them would come in with 10 grams, with 10 or 11, and they say, okay, I'll take it for 3 months, and it's not sufficient. Because you're going to take it, you're going to hit 12, but you still haven't built up your iron stores. And so most of my talk these days, because I find it so common to get globins of 8. Today I had 6.8. And she's very well. because her body has actually, adjusted as she goes along. And she herself was very shocked that she was referred because the hemoglobin is 6.8. But this has become more and more common. I found it became more common after COVID because everyone was not looking after their health very well. There were a lot of food fads that have come along, especially for teenagers. And I think, Professor Yazid, you would agree. A lot of them are not eating correct. I get a lot of anorexic patients. I get a lot of patients who are binge eating and unnecessarily wrong kinds of food. And then they go on diets. And a lot of them actually come in tired, loss of hair, brittle nails. They can't concentrate. And a lot of them actually also have hormonal imbalances, which also cause a lot of problems. And these are teenagers who are going to become pregnant moms, who are then going to become older ladies, who are going to be anemic and go through a very bad menopause. So I think overall, for a woman, we actually have to start them early and trying to educate them about iron and how to take the iron tablets, and that iron tablets are not bad. And if they cannot take iron tablets, then there are other ways of actually improving their hemoglobin status without even going anywhere near blood transfusion, and then slowly building them up. I mean, everyone wants to get ready for a pregnancy, but they never even look at their hemoglobin prior to the pregnancy. And when you look at their hemoglobin, and many times I get girls at 8 weeks, 10 weeks pregnancy, and their hemoglobin is already 11. And I'm thinking, oh no, I'm going to have trouble with this pregnancy because she's going to drop even further because the baby is going to take all her iron, the placenta is going to take all her iron, and her hemoglobin is already going to go down. And the first thing she's going to say is that, you know what, I'm going to eat iron-rich food. I'm going to tell her it's not going to be enough. So a lot of this discussion, I think, is very important from a layperson point of view of educating them that iron is really very important right from the very beginning until the very end.
Thank you, Dr. Premitha. So, I would think like the patients would really benefit out, like when you have a good discussion. Yeah, and to actually educate them and to tell them to prepare well because it affects their whole life.
Yeah, it affects the whole life, yeah.
Yes.
And also for pregnant mothers, if you're iron deficient, then your baby will be affected, right?
Absolutely.
Yes,
Absolutely.
because
Definitely.
you need iron for brain development,
Exactly.
right?
Yeah,
Yes,
I mean,
and actually, I tell them that, you want a brainy child, everyone wants a high IQ child, then you better take iron.
Yes, yeah. Iron is just not needed to make red blood cells, right? Or hemoglobin. It's needed for brain development, your nervous system, your nerve myelination.
Yeah, but I was telling that, the mother is very important. She is the most important person. So if she has got that adequate reserves, then she can handle even a difficult delivery. Her baby's born well. So, mothers tend to forget about themselves when they're pregnant, and that's really an issue. Everything is about, I need to, I need to take this soya bean because might be fair, but they forget about taking iron tablets. And I hear all sorts of things. They forget about taking iron tablets because that's really important because it might give me constipation. So the whole issue has actually changed. And I think getting them all back to, the basics of taking iron tablets and building up their hemoglobin is really very important.
Can I add on that a bit? I think what Dr. Premitha mentioned is very, very important, especially when it comes to pregnant mothers, young ladies. I mean, in 2018, if you all remember, Malaysian has been labeled as having triple burden of disease. Not just having problem of stunting and overweight in adults. We also have women in childbearing age with a very high level of anemia, right? More than 20% of our ladies have anemia, and that is something that is not very good because if you have pregnant mothers who are anemic, you're going to deliver a small baby, you're going to deliver a baby with brain that is not really fully developed, you're going to have a lot of issues. And when we have these small babies being delivered, then you have a lot higher problems of stunting when they get to their 5-year-old, 6-year-old, right? So I think there's a lot of things that we need to look at. This PBM is not just about transfusion, as what
Yeah.
Dr. Premitha mentioned. It's all about the need to take proper iron to make sure Malaysia is healthy.
So the actual numbers of 40% of pregnant mothers in this
Yes.
country is actually having iron deficiency anemia. But if you think about the numbers that are actually iron deficient, then it's
A lot
going to
more.
hit 80%, 90%. Yeah.
So you see,
Well,
yeah,
I couldn't
yeah.
agree more with Dr. Premitha, because I myself, when I was pregnant, I checked my own ferritin, it dropped from 110 to 33
Yeah.
towards the third trimester. And I can be honestly telling you that the experience of swallowing the oral iron is not very pleasant. I don't know any of you has experienced that, especially Iburet folate. To be honest, I don't blame the pregnant mothers; they are non-compliant, And the only one which is better, I think, is Maltoffer to me. Yeah, personally, I feel.
So that's a good thing that we have different types of
Yeah.
preparations. We
Yeah.
have suspensions, we have chewable tablets. So it gives them a better choice of what to take.
Yes.
It really makes you like nauseated, and sometimes it's like burning digestion, So, and the kind of like metal taste in the mouth is pretty hard to tolerate. I can actually understand they don't not comply. I would just give them IV iron, to them.
Correct.
Yeah, I couldn't
That's
really.
the answer. Yeah.
Yeah. And I
We-
think one of the entity is very well recognized is iron deficiency without anemia. Especially, I don't know whether you guys have seen it among those like marathon runners, which I saw it in overseas when I was practicing in Perth. Really, they run like 25 kilometers, 50 kilometers. They are HP not really that bad, about 12. Some of them like 11.5, but you check if ferritin is very low.
Mm.
So when we give them the IV iron, they really perform much better.
Yeah. Because
It
muscle
does
need
affect-
iron, yeah. Because muscle,
Exactly.
actually most tissue need iron.
Exactly.
Yeah, it's not just red blood cells. So most of your tissues, your brain, your muscle, your heart muscle, all
So
tissues
that
need
entity,
iron.
yeah, has to be really recognized, in my opinion.
Yeah.
Another thing I think we discussed, I think Dr. Sunita will be very experienced about it, is anemia of chronic disease, because she's a nephrologist, So
Yes.
in our side, I think this used to be called a functional iron deficiency, whereby you check the ferritin will be very high. Then people tend to jump into conclusion, IV iron won't work. But it's not true, isn't it? All this nowadays, they recognize it in the American Society of Hematology as iron sequestration, whereby they couldn't use the iron properly. Yeah. So it will be very helpful, actually, you give the small dose of IV iron together with the erythropoietin stimulating agent, right, Dr. Jameela? Yeah.
Yes.
To actually help all these patients,
So
like
you
in heart failure, renal failure.
Yeah. Yeah. So you see, iron deficiency is so common. So we've just heard about iron deficiency in children and women. And of course, you've also heard that Malaysia is the top country in Asia to have the most number of patients with diabetes, right, Sunita? Yep. And can you tell your experience in using erythropoietin and iron in these patients?
Okay, for patients with chronic kidney disease, anemia is fairly common, and it actually likelihood of having anemia increases the more severe your kidney disease is. And the main reason for that anemia is usually deficiency of erythropoietin, because this hormone is produced in the kidneys and helps to stimulate the bone marrow to make the red blood cells. But iron deficiency is actually one of the second largest causes of anemia in patients with chronic kidney disease. And, you may have iron deficiency, just like Dr. Mandy says, even without the anemia. And even the symptoms are very similar to the symptoms of iron deficiency would be very similar to the symptoms of iron deficiency anemia. It's just that we're not recognizing it and therefore not treating it. So definitely, and for us, when patients have chronic kidney disease, as I mentioned before, we'd like to sort of avoid the need for transfusions. And it's really important also to prevent cardiac complications, because patients with kidney disease often have cardiac disease as well. And by treating the anemia, you can probably improve both the kidney disease as well as the cardiac disease. And in future, prevent sort of the sensitization so that if they need transplant, then you're more likely to be able to proceed without the risk of rejection, etc.
Right.
That's good.
Yeah,
Yeah,
thank you
yeah.
very much, Dr. Sunita.
Mhm.
Yeah, so we got a nice little, roundup of, opinions from everybody. And so now perhaps we can, move on a bit to the patient experience and look at our mystery guests. And then perhaps after that, we can see if there's any other questions, right? Okay. Okay, this one is actually a newspaper cutting. And so this is from the Star newspaper, basically talking about a girl undergoes bloodless operation. And so basically Chelsea became the first patient at the Sarawak General Hospital to undergo a bloodless operation for congenital scoliosis on December 8th. Right. So December 8th of what year? That was 2004, right, Chelsea? Yes. So here is Chelsea, our guest, right?
Hi everyone.
Hi, Chelsea.
Hi, Chelsea. Yeah. So,
Everyone.
Chelsea, that's you in the newspaper cutting.
Yes,
Yes.
yes, it was me.
Right. How old were you at that time?
I was 11 years old.
11.
Yeah.
Right. So, yeah, that's it's actually a huge, a big thing to actually happen at that time, 2004, right? So at that, obviously we see here it's about scoliosis, but how severe was it at that time, And what was the treatment they initially suggested to you?
Before the operation, my curve was, I think, about 48 degrees. Yeah. So the doctors initially they told me that I need to be operated to get it corrected, my spine. And so, yeah, that was the treatment they proposed to me.
Right. Yes. So, was it an easy thing, or what kind of challenges did you face, in your situation?
Well, because it was a major surgery and I wanted it to be bloodless, so the doctors did not want to take the risk of performing bloodless surgery back then. So I was asked to just go home, and I was told that it is possible to live with scoliosis.
Yes. So you were told to go home, right? And later we'll find out actually what happens.
Yeah.
But yeah, but again, why did you actually choose bloodless treatment at that age? You're 11, right? At that time, yeah. So why did you choose that?
Okay, I am one of Jehovah's Witnesses, and for religious reasons, I do not accept blood transfusion. And it is stated in the Holy Scriptures that we must abstain from blood, and out of full respect for what the Bible says, we refrain from endorsing any use of it outside the body of someone to whom it naturally belongs. So, yes.
So yeah, so being a Jehovah's Witness, and so in that sense, you actually highly esteem the value of your own blood, also, right? As you mentioned, it mentions in the scriptures, right? But also,
Yeah.
we see what was actually done finally, because first you said they asked you to go back home, right? And then we saw the newspaper cutting that okay, there's the surgery done. What changed, and how long did it really take for it to come
Okay,
to
so
reality? Yeah,
sorry.
no problem.
So after many follow-ups with the doctors, they finally agreed to do the surgery. And after a 1 year, I should say, battle, they decided to use the cell saver machine. And it was the first time that they used it in a congenital scoliosis operation. So yes, they performed the surgery. They built up my blood count prior to surgery, and after that, the surgery was a success. Yeah.
Yeah, that's great. Yeah, so in that sense, you see, actually, the principles that they applied in your case are actually the principles that is employed in patient blood management. So if we see, history of the real history of patient blood management in the world, actually, the first bloodless surgery was actually done by Dr. Denton Cooley on a Jehovah's Witness for a heart operation, open heart surgery. And so that was the first bloodless surgery in the 1960s, yeah, way back then. And so that's how it actually progressed, and now becomes famous, like patient blood management. And yes, we still do promote bloodless surgery. Yeah, so Chelsea, how has this, choosing this procedure in a bloodless manner, how has it benefited you?
Well, without blood transfusion, there was no risk of me being infected with hepatitis B or HIV back then through tainted donor blood. So after my surgery, I was free from any sort of complications and recovered 100%.
That's great. Yeah, so, this option that you chose was actually the better option, right? Yeah. And how do you feel when you know that your treating doctors and team actually respected your wishes? How did it make you feel?
Of course, I felt happy, and I really appreciate their willingness to listen to me and my parents back then, and respected our stand on this issue.
Yes. So, this your example, yeah, perhaps, it actually gives us the idea that, well, for clinicians, it's nice to be able to kind of help the patients, and it gives a kind of satisfaction. And for the patient, it also kind of shows that you are empowered, right, to kind of make the choice that you want to. Yeah. So, any message you would like to tell doctors or also the public?
Well, to the doctors, please don't be afraid of bloodless medical approach, since it is proven to be safer, and it prevent patient from developing other complications later in life. And maybe to the public, do not be afraid to opt for bloodless treatment. We can make the right decision and protect ourselves from diseases and complications that may be caused by blood transfusion. And yeah, it's pretty much.
Yeah. Thank you very much, Chelsea. So you're
Thank
a
you,
good
Chelsea.
example. Yeah. And so we all can learn, right? Yeah.
Thank you. I think we learned so much from Jehovah
Yeah.
Witness, right?
Mhm.
Patient blood management. We have learned so much from actually Jehovah Witness, and I hope that we can actually do the same for those who don't, do not,
need.
they are non-Jehovah Witness. So because we know the benefits of, bloodless medicine.
Mhm. Right.
It's
So
cheaper actually.
yes.
Actually, it's cheaper to use,
Yeah.
IV iron and oral iron compared to blood transfusion.
Yeah.
Despite all the complication, the cost itself also is an issue actually.
So actually, patient blood management actually saves us a lot of money. It saves the government a lot of money. So
Yeah.
we should all be practicing patient blood management. So Shahnaz, so I learned that there are over 700,000 transfusions throughout Malaysia per year. Yeah.
We collected in 2019 was our highest collection. That was about 700,000 over blood was collected during that time.
Mm-hmm. Yeah.
So,
So that will come up to about in one day we are transfusing 2,000 bags of blood.
yes, correct.
Yeah. Yeah.
Yes.
So that's a lot.
Yeah.
So you were saying that one bag is 1,000 ringgit, right?
Almost now,
Yeah.
because of the costing is
Yes.
actually increasing. The reagents, the consumable that being used, all are increasing. And of course, like I said earlier, we do only serology tests, we only detect antibodies. But nowadays, we add in, because of the safety, we add in another safety layer by introducing nucleic acid testing. And that also, of course, will incur cost. But of course, in the long run, if you want to treat a patient contracting disease from transfusion compared to the screening, Just
Yeah.
imagine for HIV, you're going to cost about like 2 million per patient, you know.
Yes,
So
yes,
that's why I think government invested. I mean, they have come up with the decision to introduce 100% net tested blood to all collected blood.
Better still to
Yeah.
practice patient blood management. Imagine if we 2,000 bags a day, if one bag costs 1,000 ringgit, then we are spending 2 million ringgit a day on blood transfusions. That's a lot of money, right?
And
Right.
like
Plus,
almost 90% is actually
You don't need.
unnecessary,
Yeah.
right? Yeah.
I think there was a study by Prof Shander who says only 12% was actually necessary. Yep. So
The
it
rest
was
is
like,
not.
how much is it? 88% of the time, yeah, it's not necessary. Almost 90%, yeah, you don't actually need a blood transfusion. Of all the studies they've done looking at blood transfusion, 90% were actually not necessary. So imagine if we can reduce our rate of transfusion by 90%, how much money we would save.
Yeah.
PBM is win-win, right?
Yeah, it's a win-win. Millions.
Definitely a
And
lot.
not just we're talking about money, we are actually saving lives without blood transfusion. Of course, we always hear the promotion from blood banks. Yep. What is it? Give
I just
blood,
would like to-
save lives. But not
Yeah.
necessarily so. Donate blood, it saves life. Donate one bag of blood, you save 3 lives, but not necessarily so. Yep.
Dr. Jameela, yeah, you're right. I just wonder, Dr. Shahnaz, what's your experience about the blood collection for the past 2 years and a plus because of the COVID-19 pandemic? Initially, I think it was really like really dropping to quite a critical level, isn't it?
Yeah, correct.
Yeah.
It's very challenging for us. I mean, for the past year, I mean, not just in Malaysia, it's globally. It's a global problem where the collection drop. I mean, in Malaysia, it's about almost 20% drop in blood collection. But at that time, we managed to, sail through because of the decision to postpone elective cases at that time. So we focus only for patient who really needs blood. But like I said, it's very challenging, especially in Sabah, because I'm working in Sabah. And we have the highest number of thalassemia patients. We require monthly transfusion or even 2 weekly, some of the patients. So because of that, we had to work very closely together with the other blood bank across Malaysia, where we actually shared collection from Semenanjung, from Peninsula. They will send to us using actually TUDM flights. Yeah.
Wow.
Yeah, we use TUDM flights to send blood product for our patients. So that is how it was very challenging. Even because we have phenotype blood for thalassemia patients, we even go to donors' houses to collect blood. For patient actually, because there are a lot of MCO and a lot of restriction, movement restrictions, so donor cannot come. They have fear of coming to the blood centers, going to the hospital is very challenging. It's very scary for them. So there are a lot of factors that actually affected our collection. But of course, we have to find means to how to increase our collection at that time. Of course, at that time also, I think the clinician also practice patient blood management, where they actually that is when they started, to find other modalities, IV iron, to optimize the patient before the operation, because now they have a longer time to prepare the patient before the operation. And talking about like patient, especially in Sabah also, we have a lot of foreigners, stateless population and whatnot. We also have a higher number of patients with postpartum hemorrhage. And this is actually contributing, like what Dr. Jameela said, all muscles need iron. And when, especially in pregnant women, if they have a very low iron beginning and at the end of third trimester, when they deliver, this group of patients with, of course, higher chances of developing hemorrhage, bleeding, delivery. So again, it's like actually a vicious cycle. If you can optimize earlier, so maybe you can reduce the number of transfusion and it can be benefited.
So thalassemia is also a major health burden.
Yes.
And we can actually prevent it, by screening for thalassemia. And if you are a carrier for thalassemia, you should avoid marrying another carrier.
Right.
Yeah, because having a child, if both parents are carriers for with a thalassemia gene, then your chances of getting a child with thalassemia is 25% for
Right.
each pregnancy, you know.
Yeah.
So it's a major health burden, but can be prevented, you know, because it's very costly to treat thalassemias.
Yeah.
Blood, is so
The
expensive.
national screening has already started
Yeah.
for those 15, 16-year-old
Yeah.
children in school. But again, if you don't go to school, you miss that
Yeah.
screening.
And I think during the MCO, all this have already stopped
Yep, correct.
screening.
Yeah.
So young mothers out there, young ladies out there, please, and also young men out there, you're planning to get married, please screen for thalassemia because you can prevent it.
Right.
Because it's not easy to manage a child with thalassemia. It's a lifelong condition.
True.
Especially if you do not have a donor for bone marrow
Bone marrow
transplant, which is the only cure. Prevention is always better
Yes.
than cure.
Yep. Thank you. Yeah. So I think we have a few questions, I think, from our audience. Yeah. And so one of it is actually telling in hospital where PBM is not yet implemented, how to deal with clinicians requesting for top-up transfusion in non-life-threatening conditions. Yeah. Over dinner, we were just talking about top-up. Top-up money, but yeah, he's talking about top-up blood. Yes. So maybe from a blood bank's perspective.
Shahnaz, I would say no. Shahnaz, you're the
Of course. I
transfusion
mean, actually, you really need to look. If you have an anemic patient, actually you have to investigate first the reason why, anemia, not just immediately transfuse to top up. When we did audit in hospital, actually, when we go to the district and did blood transfusion audit, there are doctors who actually they give IV iron to pregnant women, but patient with menorrhagia, they did not give IV iron. Instead, they opt for transfusion. So I was discussing with them, probably education. I guess we need to disseminate information to them, and also to the public. When we ask the patient, did the doctor offer you any other alternative? Did you know about, they were not aware about that. I guess there's a lot of room for improvement. We have, start educating. I think as early as in the school, to educate the public and also our medical students as well. So that's the thing. Transfusion is not the answer. It's not it's not a treatment for the disease. Actually, there are conditions where actually when you transfuse, patient might develop hyperhemolysis. That's why you need to establish the diagnosis first. If it's nutritional anemia, of course, you have to give IV iron or B12 folate to treat, not transfusion. It should be the last resort.
And most of the time, it's the women who bears the brunt, right? Because most of the time they come in with heavy menstrual bleeding,
Yes,
and the clinicians will just transfuse blood. And we recently had a ABO incompatibility in a young lady, who had heavy menstrual bleeding, and she was planned for fibroid because she had uterine fibroid for fibroid removal. And they wanted to top her up before surgery. Her hemoglobin was 8, and they gave her the wrong blood.
Oh no.
Yes.
I think this whole concept about preparing the patient before surgery is really very, very important. And if things are not an acute emergency, and most times it's not, to be very honest, 90% of the time it's not. It's more of preparing the patient and giving her time with IV infusion to build up her stores and getting her ready. And I think it's more of educating the doctors. And nowadays, I think it's easier the patients know more about it than the doctors actually, because when you talk to the patients about, about iron infusion, they actually are very aware. But from the doctor's point of view, it is still something that's new. Again, it's improving. I'm not saying that, it's not there. The awareness is there. But I think we should be able to educate more and make them feel comfortable with giving IV infusion and making, all sorts of facilities available in their own hospitals, but even GPs give iron infusion now, and they're quite comfortable giving iron infusion. And we should actually encourage that.
Yes.
because and patients might feel more comfortable with their own GPs giving the iron infusion. So I think getting these avenues sorted out, clinic kesihatan, GPs, and then the hospitals, and then looking at that, all these areas of making that patient feel so comfortable, and then only planning surgery is really very important. And again, if the patient bleeds a lot during surgery and she's now hemodynamically stable, give her IV infusion again before going home, because that would be the best thing that you can actually do, and make her recover much better after that.
Yes.
Yeah, I think it's just a concept of educating everyone.
Yeah, the other thing is we need to stop bleeding also promptly. Stop
Yeah,
bleeding,
correct.
give
So,
the IV iron.
correct. So there are many ways that we can do as a gynecologist to stop bleeding. We can give them injections, GnRH injections. We can give them tablets to stop bleeding. So we can do that, but we have to then improve their own hemoglobin and get their iron stores up. So yeah, working together and then deciding what would be good for their future later on.
If I might add as well, to the question that what should you do when the clinicians are asking, say, the person that is in the blood bank has to say no to a clinician who's asking for blood, right?
It's what my MOs and I did whenever now. I mean, the clinician, because of MCO, I guess there is a blessing as well. They start, consulting us as well on how to give, what the dose and whatnot. So that is what we'll be practicing now, lah. More and more people. And I hope the specialists, especially, you train the juniors doctors, so that when they go to the district and whatnot, they are more confident of treating this patient with IV iron or oral iron instead of transfusion.
Yeah. In fact, we do have this kind of referral for anemia before operation. So to refer to us as a hematology team to investigate the cause of the anemia before they decided to transfuse the patients. I think that's a sort of the way to try to overcome, those who do not have PBM in place in the hospital. And in fact, in overseas, the blood banker who are the one holding the pager for every single PAC cell request. Yeah, Shahnaz probably can look into that.
Yeah.
And we should not allow junior doctors to request for blood transfusion. Yeah, because you must make it so difficult for them to request for, because it's so precious. Yeah, and you should not use it. Yeah, so readily.
So they are the gatekeeper to really screen through every single case, make sure they don't simply transfuse. Yeah.
Yeah, and I think also preparing the high-risk patients, like, for example, those with twin pregnancies, multiple pregnancies, previous history of postpartum hemorrhage. You can pick up these points and then say, okay, this lady I really need to concentrate on. Or even those with Rh negative blood groups, where that you can't afford to run into trouble because you're not going to get blood. So trying to learn how to pick up these patients and then concentrating on them also goes a long way in with PBM, and trying to optimize blood for these particular women. Very important.
Yes, very good. Like mention of anticipating,
Anticipating,
right? Anticipating,
preempting, anticipating.
In pregnant women, in children, basically everybody. Is it's good to anticipate, right? I think we have a few more questions here. Since we are talking about the implementation part, we'll go ahead to that question. It talks about what is the percentage of hospitals in Malaysia that are willing to do PBM, no blood?
Bloodless.
Yes.
Yeah.
Or do you have any idea, Dr. Jameela, so far?
At the moment, none. Yeah. They're willing to go bloodless, totally bloodless. I don't think any hospital is at the moment willing to do that. Yeah.
Dr. Jameela, I would like to add, you remember we have a national meeting with the Jabatan Perkembangan recently about developing a national policy for the universal implementation of PBM in Malaysia. So Ministry of Health is looking into it very seriously. Together with the Pusat Darah Negara. So I think Shahnaz is quite aware of it for the meeting. Yeah.
Yeah.
Think
We are
good.
going
Yeah.
to
It's a good
have a
start to
meeting.
me.
Yeah.
I
So
think, Dr. Jameela, what do you think? Yeah.
Yeah. We're good at making policies, but I hope we implement them,
Yeah.
Yeah.
Yeah, that's
Yeah. It's, yeah, making policies is one, but implementing, you have to
Yeah.
go to the
yeah.
ground, make sure
Yeah.
it's being,
Correct.
practiced, make
Whether
sure
it's
it's
going
being
to work out.
audited. Yeah, no point just making policies.
Yeah.
It's just paper on paper. Yep.
I mean, the one that I shared just now about the baby, it's all about knowledge.
Yeah.
If you have the knowledge, and if our clinicians have the knowledge, our surgeons has the knowledge, I think the 90% the not needed transfusion could be materialized.
Yeah.
I mean,
I
people
really-
like Dr. Premitha, doing all this, identifying cases and teach them on what the patient needs to do. We need people like that. We need a lot more of the surgeons who have that kind of thinking.
Yeah.
That it's not just topping them up before the operation, so you can avoid all these issues.
Yeah.
And you just need that 10% to just really transfuse to those people that really need it, those with thalassemia and all those blood disorders, right?
Yep.
So I think a lot of things, a lot more work by this group to go and talk to all the different societies. I mean, really deliver the message. Yeah, I think that's the way to go. And I totally agree. A lot of policies I'm involved in a lot of this stunting and obesity. A lot of policies been talked about, but if you don't deliver, you don't send out the message to the doctors and the community, it's going to be difficult. Policies is there, but things may not just run on its own without the proper knowledge of the people out there, the frontliners and the community. Yeah.
Right, that's true. So education is actually very powerful. Yeah, so it can change people, right? And perhaps there's maybe last couple of questions. I think somebody asked earlier how to properly take iron supplements. And the other question about what are the chances? Yeah, so somebody asked actually, what kind of iron supplements should we take?
Yes.
Anybody?
Dr. Pram has mentioned that there are a lot of iron supplements out there, and you may, tolerate one better than the other. So you can, you have to choose, because iron supplements, are not easy to take. Sometimes it can cause a lot of gastric upset and constipation. Yep. So the recommendation now is actually to take it every other day, because it's effective, and it causes less gastric irritation. So take it every other day. Yeah.
Yeah.
Even for children, there is syrup maltopher. If you think maltopher works for adults, for children, syrup maltopher is also
There are
there.
a lot out there, right? There's yeah.
But I think it's also how they take it, right? I mean, they take it with coffee and tea, and then the absorption's all gone.
Yes.
So taking it on an empty stomach or 2 hours between meals, I mean, taking it with, like initially you said, with vitamin C, with the fruit, anything to increase that absorption.
So proper method, and also like trying out, the medicine that actually works out with us, right? And I think there's one more question. I think it asks, what are the chances of having reactions after a blood transfusion? Perhaps Dr. Shahnaz?
okay. Okay, for blood transfusion, like I said earlier, it's difficult to predict actually. So it varies from patient to patients. Some might experience mild, but some might have a more severe reaction. But the percentage to say okay, there are literature saying that if like for acute hemolytic transfusion reaction because of ABO is like 1 in 1.8 million chances, but for the mild form I couldn't find any literature mentioning how frequent that you can develop the reaction. It very differs actually.
I think it's quite common. It's actually quite common because our blood is not universally leukodepleted, right?
Correct.
So there are a lot of white cells in the red blood cells. So
also
I've seen actually, I would say 1 in 5 would get a reaction. It's
At least
quite
a rash.
high. Yeah.
At least a rash.
Yeah, at least a
Oh,
rash.
a
It's very
fever.
common. A
Yeah.
rash, fever, because there's white cell in the packed cell of, in a bag of blood, you know.
Mm.
So these are the white cells are the ones causing all the reactions. So it's not good. Yeah.
Mhm.
And if you see in a patient with reaction, you know, with the rigors, you know, with
Rigors.
shakes and
Yeah.
all,
Yeah.
the hemoglobin will also drop after that.
Right.
You know, because the cells will hemolyze, especially in patients with thalassemia.
Yes.
Mm.
Yeah.
Right. So that's a good discussion actually we had. It was very interesting, lots of ideas.
Mhm.
And perhaps we want to think about our take-home messages, right?
Mm.
Yeah, so to kind of conclude in a sense.
Mhm.
So what maybe take-home message do you have, Prof Yazid?
To me, most important thing when it comes to anemia is to eat proper food, get good amount of iron from there. No matter whether you are a child, an adolescent,
Mhm.
an adult, lady or man, or even an elderly, with or without any chronic illnesses.
Mhm.
It's very important to identify the correct food with good amount of iron and the proper way of ingesting those foods, as I mentioned earlier.
Mm-hmm.
That's the way to go.
I would say look after your health, and that includes blood health, right?
Yes.
Yeah. So not just by exercising, improving, reducing weight, and having an overall good health, but you also have to think about blood health. So now and then, I think you should screen for iron, yeah, and look at your hemoglobin. Make sure that it's normal, yeah.
Mm.
Mm-hmm.
And perhaps I also would say, like again, coming back to the theme of our discussion and it's talking about precious blood of mine. So, sometimes we might think, would I waste my money unnecessarily, right? So if you safeguard your money, your gold, blood in our own body is much more precious than that. And so we would try to build it up, and then if we're going for surgery and everything, we want to make sure we would not waste it, or even our doctors wouldn't waste it. Yeah, so it's looking at our blood in a different light.
Yeah.
So,
So PBM is patient blood management,
mm-hmm.
and precious blood of mine is also PBM, right? So
Yes.
remember that PBM is all about the patient, how we actually, look at the patient and optimize them, yeah, especially before a surgery. So that's why the term patient blood management came about. It's all about the patient, yeah, how we can make the patient make their own blood, Yep, before a surgery, even after a surgery. Yep, that's the meaning of patient. That's how patient blood management came about. The term came about.
Right. So thank you, everybody. And thank you, everybody, for coming. And thank you to all the speakers, panelists, and our audience for joining in. Thank you, everybody.
Yeah, I hope you all learn a lot from this. Yeah,
I definitely do.
this Facebook Live. Yeah, yeah. Bye bye.
Yep.
All right.
Bye.
Bye-bye, everyone.
Bye.